Bismillah ar-Rahman ar-Rahim. Good morning, good afternoon, and good evening for all of you joining us today for this very intriguing and interesting topic presented by Dr. Noha Al-Mhaysin. First of all, my name is Ziad Adham. I'm a healthcare strategy and quality expert today. I am leading one of the largest national transformation strategies, and enough of me. Let's talk a little bit about our respected speaker of today. Talk the talk, walk the talk, patient safety leadership. A very, very interesting topic, and leadership has always been at the pinnacle of topics, really. My very dear friend, Dr. Noha Al-Mhaysin, I am quite privileged to present her to you all today. Dr. Noha is a Harvard Medical School graduate with master's degree in quality and patient safety. She graduated with bachelor's degree in dental surgery from King Saud University, Riyadh, Saudi Arabia. She joined the Saudi Board Program for Advanced Restorative Dentistry and graduated with honors. She is a member of the Scientific Committee for the Saudi Board of Restorative Dentistry in the Saudi Council for Healthcare Specialties. She holds a Quality and Patient Safety Diploma from the Joint Commission International, JCI. She is also a certified professional in healthcare quality, CPHQ, and she is a certified trainer in change management from ProSci. Dr. Noha, I have known him for quite a number of years, with more than 16 years in the healthcare domain. She dedicated more than 7 years as the director of quality and patient safety at Armed Forces Hospital at King Abdul Aziz Air Base, Bahrain, Saudi Arabia. She recently culminated this wonderful career with being the lead for innovation and creativity program in Ministry of Defense Health Services, mashallah. I know Dr. Noha to be quite passionate towards quality improvement and patient safety, and she is always really looking forward to make both national and international impact in the field. Before giving the mic to Dr. Noha to start her very wonderful speech, I want to make sure that if you have any questions, please write them down at the questions and answers section down in the screen, and we will have a session dedicated for questions and answers, inshallah, at the end of this wonderful lecture. Dr. Noha, I'll give you now the floor, and please let us be inspired as usual.
Thank you so much, Dr. Ziad. Good evening, everyone. This is Noha Al-Mhaysin. It's my pleasure and honor to be with you today. And today I'll give a speech about talk the talk, walk the walk, and the leadership for patient safety. So please bear with me for the next 1 hour. We'll be having a very hot topic, talking about leadership and patient safety. So starting with our introduction, I would like to start with some of the highlights from the news that we have seen that healthcare leaders have been taking full accountability for any failure in the process in healthcare services. So one of the outlines that was in the news was that the UK health minister was resigned after breaking the COVID-19 rules. So we can see that usually globally, the healthcare leaders are taking the full responsibility and accountability for any failure in the service in the healthcare systems. Another example is in Iraq, whereby the Ministry of Health has resigned after a fire was in one of the hospitals. The third example was in Saudi Arabia. Unfortunately, there was a fire that was in Jazan, in one of the hospitals of the ministry in Jazan, and it was on December 2015. And the Ministry of Health has shown full responsibility and owns the full responsibility, announced that it owns the full responsibility for this fire. So leaders always take the responsibility for failures in any process in healthcare system. So do leaders really play a role in improving patient safety, and what is their main role in patient safety, rather than taking the responsibility of failures? So before we start this lecture, we will start by our first poll. So I could see that we have 288 attendees. We would encourage everyone to participate, and our first poll would be, are you a leader or a frontliner? We would encourage everyone to participate. We want to know the people who are attending with us today. Are they mainly leaders or frontliners? So we can really discuss the leadership role from different perspectives.
Yeah, I can see that there is a bit of competition here, Dr. Noha. Yeah, the results are amazing.
Okay, wonderful. So by a leader, Dr. Ziad, we mean CEO, director, manager, any person who has followers, and he's really responsible in a healthcare system.
Nice. I can see that the results shows that 66% of the respondents are saying yes, they are a leader, and 34% saying no. Quite a number of leaders we have today.
Wonderful. So I think everyone could see the results, and like what Dr. Ziad said, mainly the attendees today are leaders. So let's go through our lecture, and please kindly reflect on your previous experience and probably your future plan in leading your organization towards quality and patient safety. So one question was asked to CEOs, and the question was, how will I know that my hospital is safe? So they asked multiple CEOs, how would you know that your hospital is safe? And interestingly, many have answered that when they said that when I no longer have to call ahead to let a staff know that a family member is being admitted. So the hospital director or the CEO or the leader would think that his organization is really safe if he doesn't have to pull the phone and just call whenever one of his family members have been admitted. So we always like to refer to her as a human and crossing the quality chasm. So providing safe, high quality patient care has always been a focus of healthcare executives. It's not something new or recent. However, the Institute of Medicine and the report in 1999 to err as a human have focused on building a safer health system. And that was a clear indication that efforts are needed to be intensified. So before that paper, there used to be many efforts. However, the highlights of the role of the healthcare executives and their main role in patient safety was highlighted, and that indicated to be intensified in to err as a human. So the medical errors usually don't result of individual recklessness or incompetency, and that's what highlighted by the to err as a human, that the bad apple problem is not really the reason behind the medical errors. Actually, the errors are commonly caused by faulty systems and processes and conditions that lead people to make mistakes or fail to prevent them. So mistakes are prevented mainly by design, and by designing the healthcare system to make it safer, either harder to do something wrong, and or maybe easier to do it right. So that's what aligns patient safety and make it a big responsibility for leadership, is that the patient safety is a combination of people and processes, and both elements really depend on leadership. So let's look back into aviation and nuclear industries and linking healthcare systems into high reliable organizations where we want to be in the future. So in high reliable and aviation, nuclear industries, high reliable organizations, almost every analysis of accidents have revealed a recurrent theme. And that recurrent theme is that the failure of leadership to promote a safety culture. So leadership and accreditation, I believe most of you would know about the accreditation standards. We have the national CIVAI standards, and we have the LD chapter that details and talks about the leadership roles and responsibilities and what standards are required to maintain quality and patient safety. Also, there is the GCI GLD chapter that indicates the standards that is related to leadership, looking into perspectives of quality and patient safety. And of course, there is the plain tree standards that highlights the role of leadership in engaging the patients and trying to maintain the patient safety and what matters to the patients and patient-centered care. So all of those accreditation standards have highlighted the need for interventions, specific interventions for leadership to achieve quality and patient safety. However, I'm not going to go through them in the lecture. I think most of you are aware of those standards, so you can get back to the standards and read them and look into details of them afterwards. This lecture, we're going to cover two main frameworks. The first framework is the high impact leadership, and it's an HI framework. And in that framework, they cover certain things. From that, I came up with the outline of the lecture. So they highlight the role of the leader, where the role of the leader is to create vision, develop capabilities, deliver results, and driven by persons and community. And next is the culture. And the culture is very important role that has to be specific for a leader. And third is engaging across the boundary, and that's mainly about the personal attributes. The second framework, it also highlights the same concepts. It's the role of the leader, it's the culture, and the personal attributes. And this framework is from the WHO, and it talks about the leadership responsibility. So from those both, our agenda will emerge. We will be talking about, first of all, the role of the leader. So what is the leadership role in quality and patient safety plan? Next, what are the personal attributes for leaders? What are the key attributes for effective leaders? And third, we will talk about the role of the leader and the culture. And along the way, we will cover some of the best practices, and I'll give some of the examples that we have implemented in our hospital. So starting with the role of the leader. The healthcare executive's role is ensuring quality and patient safety. According to the American College of Healthcare Executives, they have developed a comprehensive approach to ensure patient safety and equality for healthcare executives. And they came up with those elements. 11 elements have been highlighted by them, just to highlight that those are the key roles for leaders that they need to work on to maintain patient safety and improve patient safety in their organizations. We'll go through them one by one, and we will mention some examples. So starting with a strategy. Of course, that involving the entire executive leadership team and the patient safety quality strategy is very important. The CEO, together with the senior leadership team, should establish and monitor an executable vision and a strategy to achieve patient safety and quality goals. And the strategy should include clear metrics to determine the progress and adjustments. So we should have an organizational strategy, and there should be a quality and patient safety strategy that is aligned with this organizational strategy. And there should be a metrics or a KPIs that indicates and reflects the progress and improvement in patient safety and monitors the patient safety plan, and those are aligned and integrated as critical elements of the strategy. Strategy for patient safety actually is not an organizational level. In Saudi Arabia, His Royal Majesty King Salman bin Abdulaziz have came up with the national patient safety strategy for Saudi Arabia, and it was approved and standardized along the hospitals in the kingdom. Also in the NHS, they have developed their national patient safety strategy. So the national patient safety strategy probably is available in multiple countries, and all of the organizations has to be aligned with this strategy, and their measures and metrics has to be aligned with the organizational and their national strategy. Number two is information. So information is very important to leaders. Equipping the board with the tools and information to oversight the patient safety and quality strategy is really important. They can't tell how is the patient safety plan in their organization if they don't have measures or any information reports, incident reports that comes from the frontliners or from the outcome measures for the patients, and those are reflected and integrated into information and discussed in the board. The board has the responsibility of overseeing progress toward achieving organization-wide goals for patient safety and quality. Of course, the establishment and review of KPIs or indicators should be regular components of the board agenda. So the board, when they gather, they need to discuss those KPIs to come up with action plans, improvement projects based on this information results. One of the ideas that the organizations can do is to develop a dashboard. A study, a systematic review that was published in 2021, it's very recent systematic review, was looking into the dashboards for patient safety in the hospitals and what content of the dashboards really had about the topics of patient safety. So in the graph, you could see that those are the topics that usually the organizations and the studies that have been published are talking about and integrating them in the dashboards. That includes hospital infection, pressure injuries or ulcers, falls, medication-related events, and all of the other aspects that are related to patient safety. Third is medical staff engagement. So engaging the medical staff as a meaningful partner in the development and implementation of the patient safety and quality strategy, whether in the planning process and the choosing the metrics or KPIs and measuring them and developing the action plan is very critical role for the leader. One of the tools or frameworks that's really nice and highlights the way you have to engage physicians in developing a shared quality agenda is from the IHI. They have a nice framework that integrates multiple aspects and says multiple examples about how can we engage physicians in quality and patient safety. One of the things that I want to highlight is sometimes it's very important to engage physicians is to identify and activate champions in those departments and areas. There are many other ways, including use engaging improvement methods, such for example, standardize with standardizable, make the right thing easy to try, people can be more engaged. Also, discover a common purpose by improving the patient outcome that really matters to the physicians and the healthcare providers. So there are many ways that we can engage healthcare providers with. However, that's a very important role for a leader to engage the physicians and the healthcare providers in the patient safety plan. Fourth is the patient and family-centered culture. Developing a process to hear the voices of the patients. You can use whatever the measure you want. You can collect feedback from the patients. You can use a patient experience measure, integrating those voices of the patients and their families into the leadership committees and in the design and the improvement is very important. It's a critical role for a leader to be able to sustain and to achieve a high level of patient safety. Creating a patient-centered culture has been shown to improve the outcomes and also the patient satisfaction and reducing errors and costs. Again, another white paper from the IHI, if you are interested about improving the patient experience, is developing a driver diagram to improve the inpatient hospital care. And one of the primary drivers was leadership. So without leadership, commitment to patient experience or patient safety, the patient-centered culture cannot really improve and won't be achieved. What are some of the benefits of the patient and family-centered care? It improves the quality quality and safety. It improves the financial performance. It improves the patient experience results. And many hospitals in many countries are linking it for pay for performance and for other payments methods for the organization. It improves the patient outcomes. It also enhances the market share if you are working in any private sector, and it increases the employee satisfaction and retention, and also help you to achieve JCI standards or any other accreditation bodies. Here I want to highlight the ways that organizations can deal with engaging patient and family. So there is a very nice ladder that's been shared with NHS that shows that engaging patient and families or building a culture of patient and family had multiple levels. And it starts by doing to the patient, shifting to doing for the patient, and ending by doing with the patient. And just shifting from one step to another can help to improve the patient safety, and not only patient experience, also patient safety, and also minimizing the cost and improve the patient's clinical outcome. So doing to is starting by coercion of the patient and then education. Doing for the patient can be starting by informing the patients about the treatment, consulting the patient, and engaging the patients or their families and involving them in the decision. While doing with the patients is co-designing the healthcare system, and also it can reach co-production where the patient really is participating and delivering part of the healthcare service. This ladder, they call it the Arnstein ladder, and it's ladder that's in public services and have been adopted to healthcare, that shows that the customers of the service, they can be engaged in any service that's provided. So our next pull is going to be examine this ladder and look into it. Like the first two steps is doing to the patient, the three next steps is doing for the patient, and then the last two steps is doing with the patients. So we want you to participate into this poll, please, and share your perspective that mention which level have you reached in your organization. So tell us, is your organization, whether being a leader or being a frontliner, is really doing things to the patients, doing for the patient, or doing with the patient? So we want everyone to participate to have a better view of the attendees.
Yeah, there's quite a number better than the first poll, but we need really everyone to go and tune in and try to answer the question. We will be this time, I'll be sharing the results. Maybe the last time I didn't, but I'll make sure to search. Come on, guys. I think we are only 25% of the participants today are participating with the poll. Go on, check on the screen. Yeah.
I think it's a bit difficult to decide exactly where the organization is doing or performing, Dr. Ziad. However, they can just try to relate what are the main practices that they're doing at the organization, and what's the culture really in the organization.
Yeah. The results showing quite a promising level of the ladder, with the majority are saying that they are doing with the patients, which is quite refreshing, I would say.
Agree. Wonderful. Have you shared the results, Dr. Ziad?
Yeah, I think the results are shared. If Hiba can help us to share them as well. Can they be shared on the screen? Or we can stop the sharing?
Yes. So we have like 41% of the attendees are doing with the patients. So they are co-designing the healthcare service. Maybe they are re-innovating the area. They are getting always feedback from the patients, and they are involving patients in the providing the care and in designing the care itself. So one great example of co-designing with the patient is initiating a patient and family advisory council. So in the patient and family advisory council, you can expect that patients are part of your team. Patients sit on the front of the other healthcare providers, and they sit with the other leaders just to say their perspective, their opinion, and they reflect on their personal experience. And they can really give us an insight about things that we are not aware of, and we don't know about it as a leader or a healthcare provider. Another idea is to have a multidisciplinary round that is inclusive of patients and or resident or family. So we can, the leaders can conduct this round. They can include patients as part of the round. They can visit patients, include patient insights and their questions in their interviews. They can ask patients what matters to you, what do you think the best option works with you. Next is culture of safety. And in culture of safety, remember in the agenda, I said I'm going to cover the culture in a separate domain in the lecture. So I'm going to talk about more details about the role of the leader in the culture of safety. However, creating and sustaining a culture of safety is very important for any leader. It's not only linked to the leader of quality and patient safety, it's the responsibility of CEOs in healthcare organizations, medical administration, nursing, administrative, any leader in any healthcare system. Healthcare executives should prioritize enhancing the safety of patients and the workforce. And of course, small-scale incremental improvements are never enough. So there should be a dramatic changes in culture of safety to be able to improve it. Number 6 is culture of improvement. So includes an organization-wide commitment to continuous learning. An organization that continuously learn and improve can develop in multiple ways and aspects. So always invest in human capital is very critical for growing the capacity that's necessary for executing the patient safety quality initiatives and establishing a culture of improvement. Of course, improving the capacity and the capability of the peoples are going to really have a positive impact on the patient safety. Ongoing education should involve not only the techniques for improvement, it should also include some change and leadership knowledge and integrated in the continuous education of the staff. Number 7 is using best practices. So rigorously seeking out and applying best practices, well-defined and evidence-based practices have been shown to lead to improved outcomes. The use of such established best practices should be a key component of an organization's patient safety and quality. So there are many best practices. There is guidelines, well-known best practices that can really impact and improve patient safety. I'm going to give you 2 examples of, those are 2 papers that's published from the MODHS, and they were tackling improving some domains of patient safety. So the first one was reducing hospital-acquired pressure injury, and by that they managed to reduce the prevalence of hospital-acquired pressure injuries to below 4% within 6 months, and that was a collaborative improvement project with multiple hospitals participating in improving the pressure injury. The second is improving the hospital flow, and the project that we call it NCF. And in that project, they managed to minimize the boarding time to minus 7.1%. And that's really a big difference, huge difference before and after. If you want to read more about those 2 published studies, you can just scan the QR code and then you will be able to have free access to those. So those are the change packages that were implemented in those improvement projects, and those were all are evidence-based change packages. So by implementing an evidence-based solution, you can always improve patient safety. Number 8 is communication. Leaders should communicate. So providing an open communication and demonstrating a commitment to transparency is very important. Commitment to open assessment of data by all relevant participants within the healthcare organization, also by reporting results, by reporting sentinel events, by the incident reporting system, and by meeting public and stakeholder expectations for transparency, especially those of the patients. There should be incorporated also as a part of the patient safety and quality strategy. Number 9 is information system. Can information system improve patient safety? Yes, they can. If we focus on more the areas whereby adopting an information system that support the patient safety and quality strategy. And one of the ideas is to use computerized physician order entry with a clinical decision support. So those clinical decision supports can help the clinicians in taking the decision, and they are going to minimize the errors and mitigate unintended consequences of technology. Number 10 is voluntary collaborative. So encourage the organizational involvement in any voluntary collaboratives, participation in voluntary collaboratives among providers and other interested parties can provide a valuable forum for comparing data, sharing best practices, benchmarking, stimulating improvement efforts, and increasing transparency. So always working in collaboration, whether with organizations in the same system, with organizations in the same area, with different systems, can really improve the safety. And it's one of the initiatives that leaders should focus on and highlight. Last but not least is workforce safety. So protection of the physical and psychological safety of the workforce by knowing that their well-being is a priority, enable the workforce to be engaged in their work, to be more satisfied and less likely to experience burnout and to deliver more effective and safer care. One of the great examples that's even required by the JCI standards is developing a second victim program. So second victims are the staff that are affected psychologically by any sentinel events that happen in the organization. One of the ways is to develop a second victim team. So you can develop a second victim team that can support, guide, and evaluate the program. Also, you can develop a second victim support team that can provide direct psychological staff support and education and awareness to minimize the consequences of second victim as a result of a sentinel event. Another example is to provide psychological support for staff during COVID-19. So in my organization, we came up with We Care program, and that program has multiple levels of responsibilities, one on the leadership, one on the directors and head of departments, and one on the second victim program support team. So those multiple levels are to integrate the psychological support for the healthcare providers during the COVID-19 outbreak, and to be able to support them during the fear moments that they have, whether they got the COVID-19, whether they've lost a loved one, whatever is the psychological need that they have. It's very important to provide some kind of psychological support for the healthcare providers during this time. So we've covered the 11 elements. I want to relate them to the 8 steps that are recommended for leaders to follow to achieve patient safety and high reliability in the organization that have been highlighted in one of the white papers of the IHI. And those are the elements, and I believe we have covered all in the previous framework that we have used. So it talks about, again, address strategic priorities, culture and infrastructure, engage stakeholders, communicate and build awareness, also communicate the system level aims, track and measure performance over time, supports the staff and the patient and families impacted by medical errors, also by aligning the system-wide activities and incentives, and also redesigning the system and improve reliability. So our next item in the agenda is to talk a little bit about the personal attributes of leader. So let's agree that not everyone is a natural born leader. So is leadership acquired or inherent? I think it's both. So even leader with experience or professional leadership training might fail. A study by a Center for Creative Leadership have showed that 38% to more than 50% of new leaders fail within their first 18 months. So what is leadership? Leadership has many definitions. One of them is it's a process of social influence which maximizes the efforts of others towards the achievement of a goal. So leadership is a cornerstone of success. Effective leaders lead by example, a strong work ethic, and demonstrate a commitment to the mission of the institution beyond that of self-preservation. Leaders who promote a positive organizational climate contribute to higher job satisfaction among employees. Also, they decrease the amount of burnout. There will be less medical errors and an overall improved culture of safety. So what are the characteristics of high impact leadership behaviors? So the first one, what the leaders do to make a difference? What do you think the leaders can do? What are the behaviors that some of them we have talked about at the beginning in the role actually of the leader? So the first is a patient-centered care. So again and again, person-centered care is a very important role of a leader in any healthcare system. In healthcare, we manage dealing with stakeholders and customers, that customers are patients, and it's very important to have this patient and human-centered care in any interaction we have. Next is frontline engagement, and we have talked about this. So the leader has to be a regular, authentic presence at the front line and a visible champion of improvement. Third is the relentless focus, by remain focused on the vision and the strategy. So no matter how much of the daily day-to-day work and distraction, there should be always a focus on the vision and strategy. Number 4 is transparency, and that requires transparency about the results, progress, whether aims and defects that happen in the system. Number 5 is boundarylessness, and that's by encouraging and practice system thinking and collaboration across the boundaries. So what skills does the leader or the healthcare leader would need? They would need the leadership skills and management skills. A leadership skills is more about strategic thinking, will building, inspiring others, team building, communication, listening, prioritization, accountability, role modeling, and engaging. Well, the management skills is more about budgeting, staffing, measuring, hiring, ordering, planning. Both are required for any leader. So here we can see what are the key attributes of effective leaders. And in this driver diagram, we can see that there are core leader effectiveness is actually driven by his ability to manage the work, by his ability to improve the work, and by building team capabilities and by shaping the team culture. So again, we have to focus on the culture. So managing the work is mainly by managing the time and the resources. And there are many ways that the leader can use to manage the time. One of the most important ways is to be able to delegate. So leaders should have the confidence and the ability to delegate much of the work to have enough time to focus on the high priority areas. Also create a standard work processes whereby standardization of the work is going to minimize the leader's intervention. Also measure the financial quality, customer and key processes. Also surface and solve the problems in real time, engage across departmental and team boundaries, and prioritize to improve the work. They need to prioritize and align to strategy and aims, also to understand the current state, the cause and target conditions, also learn and use improvement tools and methods. So the leaders have to be aware about the focus PDCA, about the IHI model of improvement. They have to really know about how to improve the work, and they need to learn more about the root causes of the problem. They need to learn about how to reduce variation and waste, the lean and Six Sigma. If you are a leader, you can consider having certificates in those areas and also get the results and how to sustain those gains over time. Number 4 is to have the ability to build team capabilities. And by that, they need to develop the competency through coaching. So the leaders should have the competency to coach others and when to coach, and depending on which of the followers' level of knowledge and skills, and what are the ways to delegate to them and to coach them and try to improve them. Also use the whole team by working as a team member of large teams, also to be able to communicate effectively and with transparency and establish respect and accountability. Number 4 is to shape the team culture. And by that, you can share the vision and build the will, also promote transparency. And it's very important. We've been mentioning transparency more than once in the lecture. Also, they need to model the way for their followers and encourage some mindfulness and develop joy at work programs to improve the employee engagement and also keep the person at the center and focus on the patient-centered care. So here we'll be having our third poll in this question. So do you think that there is any relationship between a leadership style and healthcare setting and quality of care? And the answer is going to be reflected on a systematic review that is done on nursing leadership. So do you think the leadership style has any relationship with the quality of care and the clinical outcome? Here we'll be having our third poll. Can we share the poll, please?
Okay, I think I launched the poll right now. And by the way, everyone, last time, the first poll has 90 participants. The second one has had around 100. So please, guys, everyone, do your best. Let's hear from you. Just an answer. It doesn't take a lot of your time. So help us. Excellent. So we have reached a new level now, 100.
Excellent. You're breaking. We are breaking the level of the previous level.
Yes, actually, continuous improvement. That's a very good notion here.
Agree.
It seems to me, Dr. Anuha, that the relationship between leadership has always been with quality has always been debatable, but it seems that very few of the attendees today are not with that kind of debate. The impact of leadership style on the quality of care. I think that most of our dear participants today have almost 95% right now agree with this concept, which is quite in alignment, I believe.
Agree. So, Dr. Ziad, you know that there are many leadership styles. A leader can be transformational, can be autocratic. So there are many leadership styles for any leader in any system. So the question is, does this style of any leader, if he is a leader in a healthcare service, does it really affect the quality of care? And is there any preferable leadership styles that can improve the quality and improve the clinical outcome? And of course, by focusing on this, maybe even the education and building leaders in healthcare should have the focus more into those styles that can really improve the healthcare and clinical outcome.
Yeah, it's a very important thing that this is even reflected through the peer-reviewed studies as well, because sometimes we feel emotional that this is, I mean, the better the leader, the better the outcome of quality of care. But I believe it is even something proven scientifically to be true.
I agree. So the results, we have 94% of the 158 who have participated in the poll have said that yes, it does impact the quality of care. However, only 6% said that it doesn't impact the quality of care. So I do agree with them. And the systematic review said that leadership styles were found to be strongly correlated with the quality, care, and measures. For example, 30-day mortality, safety, injury, satisfaction, physical restraint use, pain, and etc. Leadership styles that are more effective and promoted a positive outcome, where those are as collaborative, multifaceted, and dynamic process. For example, transformational leaders, employee-oriented leadership. So those leadership styles have shown a better clinical outcome and better quality of care and patient safety. So in the last area of the agenda of today, we will talk about the culture and the role of the leader in the culture. And what is culture? How do we define culture? So culture of safety is defined by HRQ as one of which healthcare professionals are held accountable for unprofessional conduct, yet not punished for human mistakes. Errors are identified and mitigated before the harm occurs, and systems are in place to enable staff to learn from errors and near misses and prevent recurrence. So we can hear that there is no punishment. People are accountable, and we can see that there is a learning culture, and all of those define the culture of safety based on the definition of HRQ. The Joint Commission defines safety culture as the collection of beliefs, values, attitudes, perception, and competencies and patterns of behavior that determine the organization commitment to quality and patient safety. So those different definitions of culture of safety, however, they mean the same meaning, and that all of those are a culture that really reflects how we care about patient safety. So the culture of safety and leading a culture of safety, it's a blueprint of success. It's a document that was published by the IHI and the National Patient Safety Foundation. And also the American College for Health Executives have 6 domains for leaders to achieve a zero harm and to improve the culture of safety. So I'm going to go through them one by one. However, if you want to learn more about the details of how to manage the cultures and what are the tactics and the actions that you can do, you can refer to that document, and it's very detailed. You can just read more about the area that you want to focus on. So starting again with the vision. So the vision is going to improve the culture of safety, not any vision, establishing a compelling vision of safety where the goal is to commit to develop, communicate, and execute of an organization vision of zero harm to patients, families, and the workforce. So if you haven't developed a vision of zero harm, please start having this in your terminology and start to add it to your action plan and your patient safety plan. So they say that you need to develop first a vision of safety and zero harm. Next, complete and review the regular culture of safety surveys, and then conduct training to build understanding, enthusiasm for the vision among the workforce. So start by build the vision, and then try to review the culture of safety surveys. Try to educate the staff about how to achieve a zero harm, and this is aligned really with the vision. Next is clearly communicate the vision, not only to the staff, also to the patients and the public, and start to announce it in your website and in your public areas, and try to benchmark the progress of your culture of safety results with other organizations. Examples is to include zero harm vision in all communications from leaders at all levels, and keep this communication simple, consistent, and repetitive. Next is to spend some time on all the floors. Try to do leadership safety walkarounds, visit the units, and communicate with the staff. Connect about the culture of safety and the vision to the work of the frontline. And the third example is to incorporate patient and family stories along with the statistics when discussing the vision at the board level. So try to share a patient's story, a patient's feedback. Those stories can really improve the culture and align the patient safety together with your vision by discussing it with your board levels and leaders. Number 2 is trust, respect, and inclusion. So the value of trust, respect, and inclusion is very important. The goal is to establish organizational behaviors that lead to trust and leadership, and respect and inclusion throughout the organization, regardless of the rank, the role, and the discipline. So by that, provide an education and training. So always educate people about the initiative that you are doing, and try to educate them about here the respect, diversity, and inclusion. Try to implement the workforce safety program, some of the examples that we have mentioned, and also address both physical and psychological safety for the employees. Encourage and recognize and reward for reporting. Also implement communication and resolution programs with the patient whenever there is a medical error, a sentinel event, any adverse event. Always try to communicate with the patient and try to find resolution programs. Develop and share patient and provider compacts, and also participate in full transparency with the public around harm events and action plans for improvements. An example is to establish patient and family advisory council, the one that we have talked about earlier, where the patients are members of this team and they can participate in taking major decisions in the organization. Number two is to translate, for example, the tools and the resources for both patients and workforce whenever they have diversity in the between the healthcare providers and the patients, and you have different languages. Acknowledge this and accept it and start to improve the communication and improve the inclusion and respect of everyone. Track employee engagement, measure the employee engagement. There are measures for employee engagement, and also the turnover of the staff, and also use it as a metric to evaluate the trust, inclusion, and respect. The fourth example is to recognize and reward for reporting with the goal of reducing and eventually eliminating anonymous reporting. So that's an example of rewarding is a patient safety star. So whenever there is a person who's meeting the criteria of patient safety, you can consider this staff as a patient safety star, and you can reward those staff for their initiatives and activities. The next one is to select, develop, and engage the board. And by that, you need to invest in the board education, also include clinical safety expertise on the board and committees, and include the board members on rounds, conducting leadership safety walk rounds, and bring patients to the board also, again, to tell their own stories. Example is to establish board for quality and patient safety committee. If you don't have, then you need to initiate one. And then the CEO can provide adequate agenda time to review and discuss safety culture, metrics, and issues. Next is leadership development. So always invest in the leaders and prioritize safety in selection and the development of the leader. Incorporate the patient safety results in the evaluation of the leaders. So define the organizational leadership competency. Try to define a job description and competency list for the leaders that is based on patient safety. Define the processes for leadership development at all levels, and develop system training, coaching, and mentoring current and prospective leaders. And examples is, for example, a CEO that ensures that he or she and the leadership team receive necessary safety education and provide the appropriate level of safety education throughout the rest of the organization. And also, the CEO identifies physicians, nurses, and other clinical leaders as champions for safety. Last but not least is to lead and reward for just culture. So the leaders has to build a culture in which all leaders and the workforce understand basic principles of patient safety science, and also recognize one set of defined and enforced behavior standards for all individuals in the organization. An example of this is to align the systems and standards for just culture across organizational departments, including human resources, and also publicly reward positive examples of just culture. And a good idea is to use a good catch award, and I believe many organizations have implemented a good catch award, where it's a high risk near-miss that have been reported and didn't reach the patient. So by encouraging the people to work on good catch, we're gonna encourage the just culture, and we will encourage staff just by rewarding to speak up and talk about the mistakes and errors. The last is to establish an organizational behavioral expectations. And by that, an example is that every 12 to 18 months, and review with the board, the leadership team, and workforce, and set targets for improvement, and take deliberate actions to achieve the patient safety plan. Also, the next example is to implement a safety huddle. So I would like to thank you all for listening.
Thank you very much, Dr. Nuha. In the next few minutes, we will be reading some of your questions. If you have a question, please use the Q&A section in the bottom of the screen. One of the very interesting questions that probably we have heard a lot, being in the quality and patient safety domain, building a safety culture. This might seem a little bit abstract to some of us, but let's, Dr. Nuha, if you can give us some of the approaches a good question by Dr. Fatma Al-Hajri. She said, what are some of the approaches that we can shift from the theory of safety culture into the practice?
Okay, so I think you mean some of the activities that we can do, Dr. Ziad, right?
Yes.
So one of the main ways to shift the culture is to have that transparency and that availability of leaders where they can meet and talk to the frontliners. So if they can break the ice between them and the frontliners, whether in visits to the departments, whether leadership safety grounds, whether by doing gatherings with the frontliners and talk to them and show them how much the leaders are really interested and committed to improve patient safety. Second is by rewarding the good practices and rewarding the reporting. I think this really going to improve the culture of safety. If people feel that they won't be punished for their actions, if they taken, if something that happened and it's not related to like unjust culture, is not related to a mistake by the patients rather than a system issue, then the people feel that they feel safe and psychologically safe to report it and speak up about it. And rewarding those actions is really helpful in changing and shifting the culture. So the culture usually starts top-down approach. It starts from the leaders. So when the leaders start to set the tone and they start to talk about how important patient safety is, and it's not only to talk about it, they just show it by being committed, available, transparent, reward the good practices. I think really this is going to shift the needle and improve the culture of safety results.
That's definitely the case, and we have experienced this, I believe, multiple times. It's quite common for people who work in quality and patient safety for the leaders to come in and said, who reported that anonymous report? Why? And who is this person? I believe this is quite something that we are used to. So having a leader who believes in fixing the system and really working on the culture of learning, I totally agree on this very, very key element. And on that key element that really bridges the chasm, actually, is the leader. So the leader is there to build between theory and practice. And here is a very good question from one of my dear colleagues, Makia Majrashi. She says, what do you recommend with regards to building safety and quality and safety leaders within the organization? So if you want to have leaders, champions, what are the kind of attributes that they should be having, to build new leaders in this field?
Okay, so I think, first of all, the competencies, the leadership competencies that's related to patient safety and quality, first of all, has to be identified by the organization. And then the recruitment has to be based on having those personal attributes as a baseline for leadership. Next is to conduct an education, multiple education programs that's not only theoretical and it's only building knowledge, it's more of building knowledge, skills, and attitudes for leaders. And I think coaching with time is really important as well.
I definitely agree on coaching, because coaching has the ability to change behavior, not only learning new concepts or theories, which is quite important. Another very good question that is very practical, really, by Anas Amr. He says, what quick actions an organization leader can do to foster a just culture, like a couple of things that they can do right away to be able to foster this just culture within the organization?
Okay, so let's say transparency, first of all. So transparency with the leaders, let's say if we have a board of leaders, being very transparent with the results of a culture of safety, with the results of the incident reports. If the leaders are really transparent, then the frontliners are going to really have this feeling of just culture and culture of safety. That's first. Next is to include the patient safety KPIs in every board meeting, discuss it and develop action plan. By discussing this in the board and committees meeting, that would indicate how important it is.
Excellent. The last question, which maybe probably a lot of people like me has this kind of question: talking the talk and walking the talk. The famous leadership walk rounds. How frequent should they be within the facility?
I think it would be nice to do it weekly. Though I know there are multiple leaders who are busy, but then leaders can just substitute each other. But doing it weekly is very important, and including patients' interviews as part of the leadership safety walk rounds is really important, because it will help the leaders to have the insights of the patients and to listen to things that they didn't think it was a priority for the patients before.
I totally agree on this, and thank you very much, Dr. Anouha, and thank you all for attending this very thoughtful lecture that touches really the day-to-day works of all of us within the healthcare domain. I would like to thank you. I'd like to thank the Saudi Patient Safety Center for organizing this very engaging lecture and program in the sense. Thank you very much. We are out of time, and we want to be on time because we are quality professionals, and we will walk the talk and talk the talk. Thank you all very much, and hope to see you soon in another lecture. Thank you, Dr. Anouha, and thank you all.
Thank you so much, Dr. Ziad, and thank you all for attending. Thank you, Hiba, for organizing this activity, and thank you so much for the Patient Safety Center and the WHO. See you soon, and stay safe.